حضراتكم. ان شاء الله نبتدي الاجتماع العلمي العاشر الشهري لاسم الجراحه. النهارده بيشرفنا الاستاذ الدكتور علي فوزي ابورحمه، استاذ جراحه الاوعيه الدمويه بجامعه ويست فيرجينيا في الولايات المتحده الامريكيه. وبرحب باخويا وصديقي الاستاذ الدكتور وائل شعلان اللي هيعرفنا على التاريخ العلمي للاستاذ الدكتور علي.
بسم الله الرحمن الرحيم. احنا النهارده في الاجتماع العلمي العاشر قسم الجراحه، وده شرف لينا وحده جراحه الاوعيه الدمويه انها تسبونسر ذيس ميتنج، والشرف الاكبر اللي يبقى معانا الاستاذ الدكتور علي ابورحما واساتذتنا الاستاذ الدكتور رأفت نجا، الاستاذ الدكتور منير مبروك، الدكتور عمرو عيسى، الدكتور عادل امام، الدكتور نجيب العسكري، الدكتور مصطفى مبروك، والاستاذ الدكتور سامر باسم. عايز اعرفكم الاجنده بتاعت الميتنج هتمشي ازاي. انا هقدم ان شاء الله الدكتور علي ابورحما، هقول لكم البايوجرافي بتاعه، وبعد كده الدكتور رأفت نجا هيتكلم كلمتين عن الدكتور علي، وذن الدكتور علي ابورحما هيقدم 2 lectures. The first would be the carotid cerebrovascular disease guidelines for its management, and the second هيهم قوي الهاوس اوفيسرز والجونيور residents how to get USA residency and vascular fellowship. Like, who is Professor Dr. Ali Aburahma? Dr. Ali is a tenured professor of surgery, chief of vascular and endovascular surgery at West Virginia, USA, and the director of the Vascular Surgery Fellowship and Residency Program of West Virginia University. He also serves as a medical director of the Vascular Laboratory and co-director of the Vascular Center of Excellence at Charleston Area Medical Center. He attended and graduated from Alexandria University Medical School. Dr. Ali Aburahma خريج جامعة اسكندرية. He completed his general surgery residency at the State University of New York and West Virginia University and his vascular fellowship at Arizona Heart Institute. He is certified by the American Board of Surgery, Vascular Surgery Board, and Surgery of Canada in Vascular Surgery. He is the past president of the Society of Vascular Surgery of America. Dr. Ali Aburahma is the president of the Vascular Society of America for Vascular Surgery. 2021, Dr. Aburahma has an avid interest in vascular surgery and has dedicated his life to research, earning him a national and international reputation for his contributions in this field. As a result, he has published over 275 articles in peer-reviewed journals, over 200 abstracts, 125 book chapters, 8 textbooks in vascular surgery, 7 of them in non-invasive vascular diagnostics, and 1 in vascular endovascular surgery compact manual. He is also an associate editor of the 8th, 9th, and the 10th editions of Rutherford's textbook. Rutherford textbook is the mother book of vascular surgery. He also has made presentations at over 560 national and international medical meetings, including many named distinguished lectures. It's an honor to have Dr. Ali Aburahma among us today. وزي ما انا قلت ان هو هيتكلم عن 2 lectures. بحب ارحب بالدكتور رأفت نجا يقول لنا كلمتين عن الدكتور علي أبورحما لان هو ليه ميموريز مع الدكتور علي.
الدكتور علي أبورحما هو اتخرج قبليه بسنتين، انا 72 هو 70، واحنا عرفناه واحنا امتياز. الدكتور علي أبورحما دفعته كانت حوالي 800 واحد، ما كانش حد بياخد امتياز خالص، دايما اساتذتنا كانوا ياخدوا الكارير كده. الوحيد اللي اخذ امتياز طالب بكالوريوس هو الدكتور علي أبورحما سنه 70 اوفر الدفعه بتاعته واللي قبلها كده. He was very intelligent, very keen ان هو يبقى عالم، علشان كده يعني الحظ الحلو ان هو ما عندوش باسبور مصري، فاضطر ما يبقاش زينا يقعد في البلد الكبيره ديت، وراح امريكا وشق طريقه الصعب هناك، بس ما كانش عليه صعب، وانتم شايفين الابلكيشنز بتاعته والكارير بتاعه شكله ايه. سنه 78 هو حشيته بطس جه ادى محاضره، كان بيشتغل مع واحد كلنا عارفينه اسمه ديتريش، هو اول واحد يعني يعمل دراسات على الهيموداينامكس فاسكولار ديزيز، وبناء عليه هو اللي كان سيتل الفيرست ترايلز اوف اندوفاسكولار، وهو الدكتور علي ابو رحمه هو اللي عمل له كل الشغل بتاعه، مش كده؟ وعرفنا لما جه ادى المحاضره دي قال كل الاسرار العلميه اللي هو اداها. بعد كده طبعا الدكتور علي ابو رحمه تبوأ اماكن كثيره جدا في نيويورك وفي ويست فيرجينيا، وبقى زي ما انتم عارفين السي دي احنا بنتقابل انا والدكتور علي كتير في المؤتمرات في اوروبا وامريكا، وهو الحقيقه ابن البلد دي، يحب البلد ديت، وجه زار القسم، وامبارح مع رئيس القسم الاستاذ الدكتور وائل شعلان يعني نصحنا بحاجات كثيره جدا مهمه في حاجات صعبه، وبعدين طلعنا زورنا العميد وفاجئنا الدكتور علي ابو رحمه ان هو يدعو رئيس القسم، وكان موجود رئيس الاقسام الدكتور سامر فسه، انه يتبنى مجموعه من اخصائيين الاوعيه الدمويه، نواب، معيدين، مدرسين مساعدين، مدرسين، يسهل لهم، مش هيتبناهم يعني، يسهل لهم ان هم يتواجدوا فترات قصيره يتمرنوا على الفاسكولار سيرجري في امريكا، ان هو عنده دلوقتي اماكن يعني فرص تسهل له ان هو يبقى له الكلمه النافذه ان هو يخلي ناس يتمرنوا عنده. فانا بشكره على المبادره دي بالنيابه عن قسم الاوعيه الدمويه، وبوعده ان الدكتور وائل وزملائه هيعملوا اقصى ما في جهدهم ان هم يحاولوا بقدر الامكان في اقرب وقت يرشحوا بعض من تلامذتهم يروحوا عند الدكتور علي امريكا يتعلموا. شكرا جزيلا وبرحب بحضرتك
Thanks, Dr. Thanks, Dr. Well. Good afternoon. It's to me kind of a little late to the lecture at 8 p.m. But I realize this is Egypt, it's not the United States, but hopefully you are more awake than I, and I think I'm anxious to speak to you. I need to start by telling you I'm really very proud to be among you, and probably I was in this place here in anatomy classes before 99% of you were born, maybe even 100%. So I'm proud to be here, and I always feel Egypt is my real home and where my family is. I was asked to give a couple of talks. One of them is more or less medical. More or less medical, and I really felt probably the most logical presentation I would give to you is something I worked on for almost 2 years with 11 people who are the most well-known in the United States in management of extracranial cerebrovascular disease. And it happened I was honored to be the chair of putting these guidelines, and I'm sure probably some of you already seen it, and it was published at the Journal of Vascular Surgery just 6 months. But again, why I'm giving this introduction, because it would be almost impossible to summarize something we put together in 2 years, and it took around 200 printed pages to be published, to be summarized in 30 minutes, but I'm going to just pinpoint to the most important part of it, and perhaps if you want to have more details, I refer you to the Journal of Vascular Surgery, and you're going to see 2 documents. One document called the Clinical Practice Guideline of Carotid Disease, and the other one is much more lengthy called the Implementation Document. And the reason we did this, because if anybody read the aortic aneurysm guidelines 2 years ago, it was a landmark study that the clearinghouse in the United States would not recommend it for agencies in America and government and insurance company to be guidelines to follow. Why? They feel it's too extensive, too bad. So they want every clinician to emphasize on 4, 5, 6 clinical topics which are so important or controversial which make sure whether the government agencies or the one who pay for procedures follow these guidelines, because these are controversial. They don't care about something every one of us know. So they felt if you want to put guidelines, you put any details in what we call implementation document. So what I want to discuss with you today are the most important 5 topics which the group of 11 of us felt is still controversial in America and perhaps worldwide. And we also felt not only controversial, is there enough evidence, level 1 evidence, to support our recommendation. If there's enough evidence, we'll use it. If not, then we cannot give recommendation. And that's what will be our topic today, for this evening. This is the vascular center where I practice. That's not the place which looked like when I went there 45 years ago, but that's the place we established over 10 years ago. And in this place, we roughly average over 3,000 to 4,000 endovascular procedure a year, and close to 1,500 open procedure a year. There's nothing to disclose, which means I have no conflict of interest. There's no commercial thing I'm trying to sell you. And this is what I just said to you. We elected the important questions, and we thought something extremely scientific. The questions selected for guidelines were specified, use what we call the PICO framework: population, intervention, comparison, and outcome. And based on what we see on our daily practice, and for us as surgeons, we really emphasize on what we call stroke prevention. The reason I'm telling you, probably many of you might not got into the details of the CREST trial, which is the largest carotid endarterectomy versus stenting in the world. They emphasize on stroke, death, and MI. But us as vascular surgeons feel that's wrong. Because when the patient come to you to have a carotid management or intervention, they did not come to you to prevent a heart attack. Even they would rather die than having a stroke. So we said we'll look into this, but our main recommendation will be on what can be done to prevent stroke. What are the 5 questions which are going to be addressed as you see here? Is CEA, carotid endarterectomy, recommended over maximum medical therapy for asymptomatic carotid stenosis? Guess what? This has been discussed for 30 years, and still many people think it's controversial. So we said, well, let's look into it. Question 2, is the CEA recommended for over transfemoral carotid stenting in low standard surgical risk patients with symptomatic carotid disease? What is the optimal timing of carotid intervention in patient had a stroke? Should I do it in the first day, first week, 2 weeks later, or a month later? Question number 4, should we screen patients for carotid artery stenosis? Which many people in America do because it makes money. Therefore, should we really continue screening for the general population? And the final question, what is the optimal sequence of intervention in patients with combined carotid and coronary? And we have a case presented to me here with the faculty of vascular department here yesterday. Should we combine them? Should we do them alone? And if we do separately, which one we do first? Following topics were addressed in what I call the implementation document. And that's what I show you in a 2-3 slide at the end, which I'm trying not to cover. So let's address these questions. Question number 1, is CEA recommended over maximum medical therapy? And that's what I call the PICA, patient, intervention, comparison, outcome. And if you look at the end, the design preferably has to be randomized carotid trial. What is the evidence? Unfortunately, there are only 2 randomized prospective carotid trials in the world. Were done up to 6 months ago. Remember, we worked on this over 2 years, published 6 months ago. So we finished the recommendation over a year ago, before it was printed. Up to that moment, were only 2 randomized trials, which every vascular surgeon in this audience are aware of them, an American and European. The ACS, the ACAS, asymptomatic carotid artery surgery, and the ACT, asymptomatic carotid surgery trial. They both favored CA, and every surgeon here is aware of it. And to make it easy for you to remember, they cut the risk of stroke by roughly half. One of them was 55%, other one was 60%. Just remember, they cut it by half over 5 reads. Now, the ACAS was around 1,662. That's the American study. But look at the European study. That almost covered 24 countries in Europe who contribute to this study. It was double the number. And the reason I brought to this, look at the bottom sentence of this slide. It was followed up to 10 years, and it still favored carotid endarterectomies by 13% versus almost 18%, and it was significant p-value. And that's what published at Lancet 2010. So might tell me, guess what? You are giving us old data. And that's the reason we were discussing this issue. Because since then, there is no randomized carotid trial comparing medical therapy alone with carotid intervention alone. I'm going to discuss a little bit of this later on. Just recently, just before we publish our guidelines, there is a study by the Oxford Vascular Study, which also went into systemic analysis of any decent, not only randomized, large population study, great single center, vascular quality initiative of the Society of Vascular Surgery, and look at the findings. If you look to the only Oxford Vascular Study group for 2,354 patients, in patients at 5 years with 70 to 99%. Look at the stroke rate, 15% to none if the stenosis was not as significant. And if you talk about 80 to 99, which is the higher stenosis, look at the risk, 18% versus 1%. So it doesn't take you genius to know, based on this study, no, still intervention is probably better than best medical therapy. Systemic review of 56 report, over 30,700 patients. Look at the data also. Impressively in favor of carotid endarterectomy than best medical therapy. The conclusion from this study and the systemic review is still CEA was definitely much favorable than best medical therapy. So what does this mean? Remember, guidelines mean you have to give recommendation. So what the recommendation was, you see it here. In low surgical risk patients, and low means you don't think patient is going to put him to sleep and going to die. No patient who really can stand surgery. We recommend carotid endarterectomy for above 70% with best medical therapy over best medical therapy alone. But you look to the recommendation, we give grade 1, and it's not an A. A was 10 years ago. We give it a B. Why B? Because still some people question, do these people really got the best medical therapy? Means optimized statin therapy, modern hypertensive therapy, modern diabetes mellitus. So we gave it 1, but we degraded from A to B. But still, that's very high recommendation. We also agreed, like many of our European colleagues, if you're still hesitant to operate, but your patient has some of these following features. We have been following someone who has progressive stenosis, who have silent MI incidentally on the brain, MRI or the CT, or the brain ecclusency, it's too ecclusive, it's not very dense and calcified, or intraplaque hemorrhage, or a plaque area which is really large, or have spontaneous embolization using transcranial Doppler. If you have any of these features, that even make you feel better and better in doing an intervention. And guess what? Most of our patients do have one of these features. And we end up by giving, based on that, the following recommendation. Asymptomatic patient with above 70% should be considered for CEA, and because there are people who believe transcarotid reconstruction, which we call TCAR, which we have been doing in America for 5 years, or transfemoral carotid stenting in low-risk patients who have good living, means they will live at least 3, 4, 5 years, perhaps is recommended, but which is we need to, because is better, carotid endarterectomy better than transfemoral stenting or TCAR? I'm going to show you. We felt it depends on patient characteristic. What does this mean? If we are considering CEA, the answer, yes, that's fine, except if they are high risk for CEA, means this is not the right choice for them. And you look on the right side, neck radiations, previous CEA, previous neck surgery, critical neck surgery, lesion too high for dissection, like above C2, contralateral vocal cord injury, and so forth, or any type of hostile medically, patient with cardiopulmonary risk. These people perhaps should not undergo today in carotid endarterectomy. Why? They are asymptomatic. The natural history is relatively more benign than if they are symptomatic. To consider TCAR, that should be an idea. However, they should not be heavy calcified lesions. They should be within 5 centimeters of the clavicle, because you make a cut above the collarbone. To put the sheath, you need to have a relatively healthy and a reasonable length of common carotid to put the sheath in. Before you put the stent, you should not have neck irradiation or stoma, like tracheal stoma, or hostile neck, or of course medically high risk. Should we consider transfemoral carotid stenting? Perhaps in some patients, unless they are too old, because when you get too old, means the aortic arch is too tortuous, or very diseased, therefore it's going to be very risky. Heavy calcified carotid stenosis, or a lesion longer than 2 cm, or tortuous common carotid, or type 3 common carotid aortic arch, and so forth. If you have these features, then transfemoral carotid stenting is not an option for you. Therefore, you have actually 3 pathways to decide, but most of us feel probably today carotid endarterectomy is still somewhat safer. Let's look into treatment of carotid stenosis in asymptomatic patients in non-octogenarian. This was just published after we finished our recommendation. This one, they look to compare CA versus carotid stenting, conventional, mean transfemoral carotid stenting in non-octogenarian, mean this trial right away to you is selected bias, because they look to the younger generation, mean they are healthier, they have better aortic arch, they're not going to be calcified. So they said, look into this. Maybe you convince the surgeon transfemoral carotid stenting is as good. But they looked into CA versus endarterectomies. And what they took part of the carotid, the CREST trial and ACS, which is the asymptomatic carotid surgery trial. They took the patients who were asymptomatic in these 2 trials, and there was no significant difference in primary endpoint. But look at the endpoint they looked at. They combine again stroke, death, and MI. And that's, to me, we felt as surgeon is the biggest mistake you do when you combine stroke, death, and MI. Because most of people, very casual, they do for MI, but the patient don't want to have stroke. When we look to the individual endpoint, I'd like you to pay attention to this slide. Look at stroke, almost 2 to 1 in favor of surgery, 2.7 versus 1.5. In mine, it was the opposite. Death, almost the same. Stroke and death, 2.7 versus 1.6. So what I'm trying to tell you, back to the same thing. If you combine stroke, death, and MI, it might not show a big difference. But if you look to stroke or stroke and death, it's almost 1.5 to 2 as bad. Therefore, if you read the conclusion, you will think they were equal. But if you read the article, you realize, no, it's not unequal when it comes to stroke and death. 0 to 14 days after index event, means after the stroke. However, a very respected figure by the name of Naylor from UK, but a single series, he claimed 30-day stroke and death rate of only 2.4% if you operate within 48 hours. He actually visited them. He had actually stroke unit where these patients admitted to that unit, and once they get the workup, within 48 hours they are pushed to the operating suite. That's not my practice. Other registry I'm going to share with you, and data from Germany, big time numbers. Sweden, US, and single center, big large series, and probably the biggest is from the SVS Vascular Quality Initiative guideline, and that's actually few thousand patients. It showed that if surgery performed in the first 48 hours, it was not as safe than if it's done between 48 hours and 2 weeks. That's the evidence of almost over 15,000 vascular registry. So we felt we really cannot take one single center of small series and take it as a recommendation. And with that in mind, something happens here. With that in mind, we gave a recommendation to operate on people who had a stroke, but you don't operate on any stroke. It has to be stroke with less than Rankin scale of a 2. 0, 1, 2, but not 3 and above. And these are disabling, but these are the ones you're going to either have a hemorrhage or kill them. So it has to be a mild stroke or non-disabling stroke. And then when you operate beyond 48 hours, but preferably before the end of week number 2, and we give it a recommendation of 1B. In patients undergoing revascularization, our evidence also showed carotid endarterectomy was safer than carotid stenting, which means go back to symptomatic patient. Still, carotid stenting did not do as good as endarterectomy. Question number 4. Is screening for asymptomatic carotid stenosis recommended in the general population? And with what evidence we found? If we do screening and found to cut the risk of stroke and to be cost effective, if you screen the population, you have to have significant carotid stenosis of at least 20%. With prevalence of less than 5%, based on literally all data published in the English literature, less than 5%, we did not feel we can recommend the screening on the general population. The position was supported by multiple organizations, as you see here: Canadian National Stroke Association and United States Prevention Task Force. The recommendation, therefore, is what you see here. We recommend against routine screening for clinically asymptomatic carotid stenosis in patients with no cerebrovascular symptoms or significant risk factor for carotid artery disease. And we give this a grade 1B. And why we do this very important, ladies and gentlemen? Because in every state in the United States, in the 50 of them, physicians all over, kind of physicians, including general physicians, who have ultrasound machine, and anybody coming with a flu or cold or whatever you want to, they screen their neck because, forgive me, it's a few $100s. Therefore, we felt extremely strong, and the United States government was very blessing of this recommendation. However, there are some high-risk patients who might have roughly 20% incidence of significant carotid stenosis. Like what? If you notice from this table, look at the middle. Patient with PAD, the risk is almost 18%. If you have PAD and coronary disease, it becomes higher. And from there down on, it looks like the risk is close to 20% and above. These type of patients, we feel, for that subgroup, perhaps it's recommended to screen. And we give it a grade 2B, and I give you an example here. People who come to you with lower extremity PAD, patient undergoing carriage, patient above the age of 55 with at least 2 traditional atherosclerotic risk factors, hypertension, atherosclerosis of any kind, triglycerides, anything you want to, diabetes mellitus, or patients above 55 years old who are active cigarette smokers. These also, United States government pay for the testing. Final question of this recommendation is, what is the optimal sequence of intervention in patients with combined carotid and coronary disease? In patients with symptomatic carotid stenosis, like the one which was presented to me yesterday, with 50 to 99 who require both CA and CABG, we suggest CA before or concomitant with the CABG to decrease the risk of stroke. This is if your team, your center, have definitely finding of a stroke and death which is acceptable in your institution. If not, start with the carotid if it's symptomatic first, then follow the CABG. In patients with severe unilateral with carotid occlusion or severe bilateral like 70 to 99, we treat them with the same, similar to the one with symptomatic patients, and then suggest CEA before or concomitant, it depends, and again, in your institutions. I don't mean concomitant bilateral endarterectomies, I mean only one side. In patient required carotid intervention, stage or synchronous with coronary intervention, decisions between C and CAS are based on grade 2B, timing of the procedure, need of anticoagulation, patient anatomy and characteristic. Now, I'm not going to really be able with the timing to cover this, but I'm just running you what the implementation document cover. Look at covers almost 15, 20 items of carotid. As you could read this as good as I. Still, that's all in implementation document. Still in the implementation document. However, I'm going to give you 3-4 slides of some recommendation. Some recommendation, duplex ultrasound performed in an accredited laboratory. I don't know about Egypt where they have accredited vascular laboratory by National Council to accredit vascular, but if it is, we believe that can be equal to anything else, and you could operate on it if it's accredited and you know your lab and you validate your testing. Otherwise, we add always another recommendation, like for example, getting a CT and so forth. And this is what I just said, whether CT or MRI, if you are not sure about defining your ultrasound. Choice of anesthesia, extremely controversial, but I'd like to refer you as what I said yesterday, the GALA trial, Italian, impressive multi-center study, multi-prospective, comparing local and general, and the outcome are exactly the same. So local, general, it doesn't matter. Do it to whatever your anesthesiologist feel is comfortable with. So there is level 1 evidence to support the recommendation in favor of routine carotid patching also, or carotid eversion. This is a type of closure. I don't want to go through it because I'll take all evening. Carotid access, proper imaging of aortic arch. I think you probably know this for sure. Unless you are doing transradial or transbrachial, if you are going for left carotid lesion or bovine anatomy. And of course, I bet you most of you probably are anxious to know about TCAR. I will cover it in a second. For the next 2-3 slides, we have done now a few hundred of these. This is really almost going like gas on the fire in the United States. In my practice, I would say 10 years ago, 15 years ago was 100% endarterectomies. Then 10 years ago, maybe 90% endarterectomies, 10% transfemoral carotid stenting. Nowadays, in my group, including myself, 70% conventional endarterectomies, 30% transcarotid stenting. An inch cut above the collarbone, and you want to be going to cut while you do the endarterectomy. That's the reason I personally still do more of endarterectomy, but my younger generation feel better by doing 1 inch cut above the collarbone, expose the common carotid artery, put a sheath, and then through the sheath, you put the wire and you put your stent. You might tell me, heck, why didn't you just do transfemoral? You're going to put a stent. The dilemma with the transfemoral, that's why the stroke rate was twice as much as endarterectomy. You have to cross the aortic arch, and many of these 70, 80 years old have tortuous arch, calcified arch, disease arch. So you are really avoiding all these terrible country road in West Virginia or in Egypt. You're going straight to the highway. And that's really makes sense when it comes to the theoretical advantage of it. And there are multiple studies, roster 1, roster 2, Aburahma studies, SVSP-QI data, which showed stroke rate as half as transfemoral and almost as good as carotid endarterectomies. But we do need long-term data because the longest data, whether in my study or the roster studies, are only 1 year data. And these are just some references for the DCAR. I'm going to skip this, Professor, for the sake of time.
No, thank you.
And I go with the, I don't mind really doing something related to restenosis following carotid stenting. Quite many people are curious, if I have restenosis after endarterectomy, should I do surgery? Should I leave him alone? In one capsule, if it's endarterectomy or stenting and symptomatic, you treat them as the primary disease. The dilemma is they are asymptomatic. For endarterectomy, it's being shown by meta-analysis of multiple data, after 5, 6, 7 years, they might be becoming more symptomatic than if after stenting. Therefore, for asymptomatic carotid endarterectomies, there's still more American who will do an intervention. Because the intervention is simple, just carotid stent, probably through the TCAR now. However, for asymptomatic carotid stenting, 99% of the time, they are naturally benign. Therefore, people tell you, honest to God, the truth, that's the only artery they have, they are, and of course, they are healthy, you might be doing an intervention. So I'm trying to leave you with one thing. For asymptomatic recurrence after stenting, do not do anything unless you have to. Let's give you roughly a summary of what I just did. Finally, I believe the post-carotid intervention. Quite many American, again I don't know about Egyptian, because, forgive me, it's money-making. They get an ultrasound almost first month and every 6 months and every year, and sometimes for 10, 15 years. The recommendation of our guidelines as such. You do it the first month to know what it looked like after you did the endarterectomy or the stenting. That's the first study. Then you get 6 months later, perhaps between 6 months to 1 year. And if it's normal, you are liberal if you do it one more time. If normal or minimal disease, you do not need to do it, and we do not recommend it to these patients. And we leave you always brag and say, this is my house. It's unfortunately it's not. This is I call the West Virginia White House, which I'm not joking. It's called the Green Rock Resort, which Dr. Aburahma uses it for his annual convention every October. And it's supposed to be the most beautiful place in America when it comes to resort. It's a hotel that always brag about and say, this is my house, but I'm not that rich to have that house. So we call it the White House of West Virginia. But if anybody ever comes to West Virginia, they call it the Green Rock Resort. Well, the Congress of the United States, I'm not joking, around the third week of October, they spend around $20 million from Dr. Aburahma's tax money and everybody else, and they spend long weekend at the Green Rock. This is where the United States government actually held their meeting every October, and for people it's not a secret anymore. There's something there called the bunker. You never know, there's something under this White House, which is huge, around 30,000 square feet, where the United States government were holding their secret meeting if Russia, at the old days, bombed nuclear the White House and Washington. I promise you. They call it the bunker, and it is very historic, and now it's open for the people to come and see it. Yes. Thank you very much for listening.
I think the floor is open for discussion. If anyone has a question for Dr. Aburahma.
Dr. Ali, if you have a soft plate,
It's wrong.
a soft plaque,
Yes.
soft plaque,
Yes.
does it make a difference in
Might
taking
impact
the
the
decision?
might
I mean,
impact.
is it safer to stand or safer to?
Actually, this, if you pay attention to one slide for the younger people, when I said also we added one slide, if you have the following features, it makes you feel even stronger for intervention, and that feature is ecclusive plaque or soft plaque. Yeah, absolutely. If you have good ultrasonographer, you could tell whether it's soft plaque or not, and that make you, but still you don't operate on it with 50% disease. In other words, if there is significant carotid stenosis and you're hesitant to operate, but the plaque is soft, I highly recommend a carotid intervention. Carotid intervention, and preferably endarterectomy, not carotid stent. Yes.
Thank you, sir.
Let me start by, before any question, I do apologize for running through this too fast, but I promise you, that's 2 years of work by me and 11 people to put these guidelines. So it was no way when Professor Wael told me, let's finish it in 30, 35 minutes. Okay?
I'm very proud to announce that Professor Wael Shahlan, 15 years before, he had published from Chicago the contents of the carotid atheroma in calcium and how this can be stabilized, stable or not. This was published by Wael Shahlan.
Actually, to make you feel proud, guys, since I call myself Egyptian for 50 years, this guy was with a guy which I know very well, also another Egyptian called Hisham Basyouni, who was in University of Chicago, and most of his work in carotid was with Professor Christopher, and it was in the carotid plaque morphology. I admire that work, period. Yes. Guys, you are all open for any question, or you could catch up with me. I'm here another 2 hours. I don't sleep till 2, 3 in the morning before I hit the Roxor tomorrow. So you could catch up with me.
I have a question about the patch. If you are doing a standard carotid endarterectomy, there is any difference between synthetic or venous patch?
That's a good point. Again, I refer you, since you are one of the young stars rising, that's very well detailed, almost 10, 15 pages in the implementation document. There is no level 1 evidence to support one patch is better than the other. However, there is one patch which in America was taken off the market after Dr. Aburahma published a study, a randomized trial, comparing something called HemoShield dactyl patch. And I hope what you have in Egypt is not that patch. They call it thick dactyl patch, is 0.6 millimeter. That's the only patch which are thrombogenic, but that's not included in the analysis. Why? Because it's no longer used in United States. But use any patch you feel comfortable with. Yes.
Our next presentation will be directed to the young staff and the house officers and residents. It will be about the USMLE and how to get residency and fellowship. And why we chose this topic? For 2 reasons. The first is that Dr.Ali Aburahma is the director of the residency program and fellowship program in West Virginia. And the second, كلنا عارفين الاهتمام of the young generation ان هم يعملوا USMLE ويسافروا حتى الاوائل منهم يعني. فاحنا حابين ان هو يكلمنا عن الموضوع ده، واذا كان في اسئله منكم بعد البرزنتيشن ان شاء الله.
Thank you. Actually, I was telling Dr. Wael yesterday, in my office there is around 600 presentations and everything on the new hospital except this presentation. So when he asked me to do it, I realized he must not really like me very much. So I have to spend several hours asking my secretary and library to get me some stuff. And believe it or not, I learned personally some of the stuff I'm going to share with you. Okay? So it could be a good experience to all of us. Residency program requirement for what we call IMG, International Medical Graduate, and it happened I was one of them, except it was a little bit easier when I applied 50 years ago. I was in Aramco, which is the American hospital in Dhahran, Saudi Arabia, as house officer after I left Alexandria. And it took only an hour from my chairman, who was an American, Professor Taylor. He called State University of New York, and within 24 hours I got acceptance. But of course, after I passed the exam. So I'm trying to tell you it's not that easy anymore. But it can be done. And I encourage you very strongly, if you want to pursue your education, to go and take that track. Nothing to disclose. The resources which I ended by looking into, the AMA, the American Medical Association, the National Residency Match Program, the ERAS, which is the Electronic Residency Application System, and the ECFMG, which most of you, if not all of you, I'm sure heard about it. And of course, you need to know a little bit about visa information. I don't know whether you need this or not, but if you do, the lecture is going to be in Dr. YL domain. You're most welcome to get in touch with him. You could click and it'll give you all the access you want to related to the link of all these. This is the MA. This is the NRMP, which is the match program. You cannot get residency anywhere. You remember not like what I got 50 years ago, where doctor calling your behalf and you're in. Unless you want to go and spend 2-3 months working with Dr. Aburahma, just in person, you know what I mean? But to have residency, you must know about the National Residency Match Program, because this is where you put your application to match in various residency programs in the United States. The ERAS, this is where your application goes, electronic application. And that ERAS is connected to every program in America who's accredited program, not non-accredited program by the GMEC, the Graduate Medical Education. But I think what you need to know the most is the ECFMG, because nowadays, when I took my exam, they have nothing to do with me. It was a doctor calling on my behalf to go to New York. But this council is the one who will deal with anything you want to deal till you get your residency. Educational Council for medical graduate, and the IMG must have certification by SMG, which is the standard evaluation of all applicant, the qualification of physician, and they even know whether your medical school is one of these schools which they accept. Not every medical school in the world is sponsored or endorsed or accepted by the CMG, and that's the link to it also. And finally, the visa information here. You need to know this stuff. Why? Many hospitals like mine, small state, they don't really want to do too much work to try to get you a different visa, even if you are the best in Egypt. So most of the places, including ours, they only accept J1 visa. So when you apply for a visa, that's the visa which probably you're emphasizing on. You could get a business visa. Visit whatever you